without further ado, I would like to introduce our speaker. And our speaker is Dr. Halima Dawood. She is an infectious diseases specialist physician with extensive clinical expertise and a long-standing history being frontline involved in the comprehensive management of patients with infectious diseases. On top of the fact that she is an infectious specialist physician, she is also an epidemiologist. She's got more than 20 years of experience in infectious disease management. She provides clinical support and technical advice in the initiation as well as the management of complex HIV and ART patients, COVID-19, as well as the spectrum of general infectious diseases, both at hospital as well as clinical level. So without any further ado, I will be handing over now to Dr. Halima Dawood for the presentation for today. Over to you, Doc. Thank you.
Okay, thank you very much. So what I thought I'd do today is share with you two cases that I've personally managed and to sort of impart the challenges that we face in the management of patients currently in the setting of HIV/TB. So the first case is a 56-year-old woman who had a history of hypertension, chronic kidney disease, and was HIV infected. She had a 5-day history of anosmia, which is a loss of smell, and anorexia and malaise. She tested positive for COVID-19 via PCR, and then was admitted initially only requiring oxygen via 40% face mask. And then when her oxygen requirements needs increased, she was referred to us because of worsening hypoxia. So past medical history in terms of treatment, she was on enalapril 10 milligrams twice a day. She was currently diagnosed with chronic kidney disease and was being worked up for this at her base hospital. But she was diagnosed with HIV infection in 2008. She was started on tenofovir, emtricitabine, and efavirenz. And then in August 2014, she was changed to second-line treatment, which was zidovudine, limivudine, and Eluvia because of virological failure. And then in March 2018, she was changed to abacavir. And the reason given to us was renal impairment, but I suspect there was renal impairment together with anemia. So she was changed to abacavir, limivudine, Eluvia. And then in October 2020, she was unable to tolerate the Eluvia and she was changed to atazanavir ritonavir. So this is not an unusual management in ART. We have to change regimens depending on the disease course and the comorbidities of our patient. And she reports no history of any opportunistic infections or tuberculosis infection. On examination, her BMI was on the high side, it was 39.5. So as we note, she has hypertension, chronic kidney disease, and a high BMI, all risk factors for COVID-19. And she had this increased work of breathing, using all her accessory muscles of breathing, and decreased air entry bilaterally, particularly in the bases, with coarse crepitations heard throughout the lungs. Now, I mean, this assessment is a difficult assessment to make in the setting of COVID-19 because you're wearing full PPE, your stethoscope doesn't fill properly in your ears, so you may not pick up all the clinical signs. So that's the first challenge in managing patients in the setting of COVID-19. In terms of biochemistry or admission bloods, the only abnormality to note was the creatinine was slightly elevated, so it didn't really look like chronic kidney disease, but it may be that her creatinine improved after she was taken off tenofovir. But what stands out is her lymphocyte of 1.12, and we see that we've seen a lot of this in COVID, but before this, we saw it a lot in HIV infection. And then the lactase dehydrogenase was elevated, and we see a lot of this in the setting of COVID-19 because it's an indicator of lung inflammation. The C-reactive protein was elevated, the D-dimer is all an indication of an inflammatory process. Her cardiac enzymes were normal. Her CD4 at that point was 214. Viral load previously was 946, in excess of 900,000, but it seemed to have come down to less than 5,000. So our assessment was that of a patient with COVID-19 pneumonia, probably in the hyperinflammatory phase of the illness and with renal impairment, hypertension, and a viral load that was not currently suppressed. So initial management is we started her on a CPAP device, and that's continuous positive airway pressure ventilation. So it's a non-invasive form of ventilation that we have these new wall-mounted CPAP machines. We gave her a PEEP of 10 centimeters and a FiO2 of 100%. We started therapeutic Flexane because we suspected that she may have a pulmonary embolus, but we didn't have any evidence yet of a pulmonary embolus. And in the setting of COVID-19, especially acute COVID-19, it's very difficult to get a bedside unit to make the diagnosis of pulmonary, to move the patient to the CT unit to do a CT scan. And in view of a worsening hypoxia, we thought that she would benefit from therapeutic anticoagulation. Her dexamethasone was continued at 6 milligrams IVI daily, and we elected not to start her on antibiotics because we didn't think we had any evidence of an infectious process. So following the initiation of the CPAP, she maintained a peripheral saturation at between 92 to 94% and looked like she was on the way to recovery. So on day 7, we noted there were some abnormalities or worsening of her C-reactive protein. Her renal function became worse, but she did not increase in oxygen requirements, and she seemed to be maintaining her saturation. We suspected that because of the renal impairment and the raise in the C-reactive protein, we did a septic screen and started her on empiric renal dosing of piperacillin or Bactam, because at that point we were concerned that she may have acquired a nosocomial infection. She was deemed, we also consulted the ICU, and she was deemed a poor candidate for ICU. And then the blood culture came back positive quite rapidly, like in 48 hours, and it isolated coagulase negative staphylococcus. And that usually is a contaminant if you don't have any other evidence of a site of infection. So it's normally a skin commensal, and if you take blood cultures incorrectly, like in the setting of COVID-19 with PPE and don't sterilize the skin appropriately when you're taking the blood cultures, that can contaminate the blood cultures. So on day 10 of the admission to us, which is day 14 post-COVID swab, which was day 3 empiric treatment with piptazo, she made a clinical improvement. Her white cell count decreased, her C-reactive protein seemed to be decreasing, and the D-dimers, which was initially 0.57, was now 1.58. And if you remember, I told you we had started her on anticoagulation already. So this seemed to be increasing D-dimers, but we couldn't explain why the D-dimer was increasing when the C-reactive protein was coming down. But clinically, sometimes there's a lag between the inflammatory markers. So she was weaning nicely to a non-breather mask. So we managed to get her off the CPAP machine, and her saturation was 98%. And our plan was to do a CT pulmonary angiogram to exclude a pulmonary embolus when she de-isolates from the COVID ward. So she was day 16 post-COVID diagnosis, day 5 empiric antibiotics, and we were able to transfer her on to the general ward. As she got to the general ward, she desaturated to 50% saturation and a non-breather mask. And on clinical examination, she had a new finding of grade 2 bilateral pitting edema, fine basal crepitations, and a S3 gallop, which almost indicated that she was now in cardiac failure. Her blood gas again confirmed a reduction in the saturation with the SATs of 87%. And biochemically, her white cell count had gone up. The C-reactive protein was on the downward trend from 151 to 85. And a procalcitonin, which is also an indirect marker of infection, was 0.02, not indicating sepsis. So assessment at that point was that the patient had cardiac failure, volume overload. We considered, did she have an opportunistic infection? In particular, we were considering tuberculosis or nosocomial or other opportunistic infection like pneumocystis carinii pneumonia, or did she get another nosocomial infection? So we reconsulted ICU because now the patient was no longer in isolation for COVID-19, and they once again deemed the patient was a poor candidate. We escalated the antibiotics to cover a broader spectrum, including Pseudomonas. So we escalated it to imipenem. And because we considered pneumocystis carinii pneumonia, we started her on high dose spectrum. And we also gave her some furosemide for the pedal edema, reduced her normal saline fluids from 100 mLs per hour to 40 mL. So what's important to note here is as she got transferred to the general ward, nobody paid attention to the fluid she was getting, and nobody thought to stop the fluid intake. So she just continued on what fluid she was getting in the COVID ward. And then we put her on strict input-output monitoring. And we started on high flow nasal oxygen, which is another form of non-invasive ventilation, but she required maximum high flow, which is 60 liters per minute with a FiO2 of 100%. And she managed to come back up in terms of saturation, but she was still sitting about 90 to 92%. And this is what her bedside chest radiograph looked like. So you can see it's a very concerning chest radiograph, almost looks like ARDS, and I mean, this sort of patient should go to ICU. So I have a polling question, and I hope this works to try and poll the question. So I just want to check if we'll be able to present the question.
Please go ahead, Doc. Let's see how we can get it done.
I think the questions are on. Shall we leave the questions out because we need to? It's a different presentation.
Good. So
okay.
The poll has come up on our side, Doc.
Okay, I can see it. I think the audience can try and attempt to tell us what they think. So the most likely diagnosis in this patient. So I presented you what we thought, but I just like to know what you think could be the likely diagnosis. This is the host and panelists can vote, but I don't see. Can somebody tell me if people are voting, because I don't see that part.
I have the same screen on my side as well, that I can also not vote, but we will see. Okay, so the results are starting to trickle in, and there's quite a number of colleagues that have answered. I think maybe, Doc, if we could just give them another 20 seconds, those of them that are still pondering the response, and then we can close the poll.
Okay, thank you. So I see about 40% think it's a COVID pneumonia, 29% thinks it was ARDS, 27% thinks it's PCP, and about 2% think it's a nosocomial pneumonia. So I think everybody at this point will be correct, because it's difficult. We don't have any evidence to sort of have a definitive diagnosis, because we have no supporting evidence that this is the PCP. But in our country, the way we make the diagnosis of PCP, we need to consider it as a differential diagnosis, and then we look at supporting biomarkers to suggest whether it's PCP or not. And I just want to reshare my screen. Is everybody seeing my screen?
What I'm seeing on my side is your question one, the most likely
diagnosis. Okay, that's
diagnosis.
perfect. That's where I need to be. Okay, so ARDS, that's an important consideration, because you have a patient who had COVID pneumonia and they present with the ARDS-like picture if they progress from COVID-19. But just to bear in mind that this patient clinically improved, was able to de-isolate. So we had a clinical stability, oxygenation improved, and then she deteriorated. So ARDS is normally a clinical progression of worsening hypoxia, and then the patient gets worse as you progress. So this was a sudden deterioration. She was deemed well and then transferred out of the unit. COVID-19 pneumonia, and for the same reasons, she seemed to be on the recovery track for COVID pneumonia. Her C-reactive protein, etc., was improving. And then nosocomial infection. I mean, any person in the hospital in COVID pneumonia, in a COVID unit, can get a hospital-acquired infection. People say everybody's wearing PPE, but what's important in the setting of COVID pneumonia, we don't change our gowns between patients, etc. So from a contact perspective, we're not having good infection prevention. What we're having is good respiratory protection, but the other aspects of infection control and prevention are not optimal. So that's just important to bear in mind in the setting of COVID-19 management. So the next step in the investigation, so I sort of gave you a hint about what we did, but what would other people consider an important investigation? So I gave you some of the other suggestions that we could do. So just remember, the patient initially had some investigations and then deteriorated. Okay, I think, thanks everybody for your responses. So as I said before, we needed a CT chest because at the very least, we needed to confirm the diagnosis of pulmonary embolism. And then in view of the clinical deterioration, we need to see if there was a complication, firstly, of COVID-19 pneumonia or something new that was happening in the chest. I mean, a chest radiograph, as you can see, was not very helpful. A bronchoscopy would assist, but generally we would only go to bronchoscopy in this sort of chest radiograph after we do a CT. So that is definitely an option, but after the CT. Induced sputum, that is an option, but you need to be specific what you're going to send induced sputum. So in this instance, we would like to send induced sputum for both pneumocystis pneumonia and tuberculosis. And you need to be careful when you're doing induced sputum, especially in the setting of COVID-19, that you need good ventilation and people who know what they're doing. So generally during COVID-19, we stopped all induced sputum because of the risk of spread of COVID. But just remember, if you have the capacity to do induced sputum, then you need to be sure you do it safely in a setting where you can do it, prevent spread of infection. And then cardiac enzymes, nobody agrees that we should do cardiac enzymes. Okay, so the next step, okay, so the additional investigations we did was we did a CT pulmonary angiogram, and it showed no features of pulmonary emboli. But what we did see was a diffuse ground glass opacification, which a crazy paving appearance noted bilaterally, some mild bronchiectasis within the lower lobe predominantly, and the differential diagnosis was, is this a cryptogenic organizing pneumonia? Now, this is a complication of a viral pneumonia when post-pneumonia, the lung starts to organize, and then you get this sort of features, crazy paving features on the CT scan. We did do the cardiac enzymes. As you can see, the top I was within normal levels. In addition to that, we screened for CMV and toxoplasmosis serology. We did a beta-D glucan, and I'll speak later about the sensitivity and specificity of the beta-D glucan. And in light of the raised viral load, a decision was made to continue the high-dose spectrum and start empiric treatment of clindamycin. Now, the reason we started clindamycin was we were suspicious that this may be resistant PCP because the patient was already on steroids, already had Bactrim on board and still deteriorated. So we suspected whether this could be resistant pneumocystis carinii pneumonia, and we increased the dose of steroids. So remember, the patient was on 6 milligrams of dexamethasone, which is, although it's a potent steroid, is a fairly low dose of steroid, and we require much higher doses of steroids in the setting of PCP. So exactly what's on this slide is what I've just said, that we increased the dose of steroids and added clindamycin. So the patient's serology for CMV and toxoplasmosis came back negative. As I said before, her viral load was just under 5,000. And we stopped the clindamycin when we realized that the dose of steroids was low dose steroids, and we increased the dose. And I was only consultant at this point. And she had already completed more than 14 days of high dose Bactrim. So I dropped the dose of Bactrim, continued the prednisone at 40 milligrams daily, and she was nicely recovering, was able to wean off nasal prongs. But she had a prolonged hospital stay, and she was discharged on home oxygen. So, Dr. Fusa, I'm not sure if you want me to pause here to take questions or to continue with the case.
Yes, so thanks for this opportune moment, and I can definitely see that the audience is definitely very engaged. Thank you so much for your virtual participation in this event as well. There's an anonymous attendee that complimented you first, Doc, for an excellent talk, and they also would like to find out in terms of your take on inhaled or nebulized anticoagulants in the management of COVID pneumonia, as is the case that there are clinical practices, for example, using nebulized or inhaled anticoagulants for ARDS, or for example, for people with smoke inhalation in the lungs. Any specific thoughts that you have on your side in terms of using inhaled anticoagulants specifically for COVID pneumonia?
Okay, so that's a very good question. And initially in the start of the epidemic, so that's more than a year ago, sort of March to about June, there was a suggestion that inhaled heparin may have an antiviral effect. There were small studies done, and the evidence was not robust enough to proceed to bigger randomized controlled trials. So that's for the inhaled anticoagulation, and I think they were looking specifically at heparin, because there was a suggestion that it may have antiviral effects. So it's not sort of robust evidence-based treatment, and currently we don't recommend it in clinical practice in South Africa. But what's of interest also is that anticoagulation, that's subcutaneous anticoagulation treatment, in the setting of COVID was also, initially we couldn't understand. We were seeing very high D dimers. I think the highest D dimer I saw was like 15 so far in the COVID setting. And initially we were starting patients on therapeutic dose of anticoagulation because we thought that there was a predominant thrombosis effect that's affecting our outcomes, because we have really poor outcomes in patients that advance with high D dimers in the setting of COVID-19. But the evidence that's emerged is that then what emerged was prophylactic anticoagulation, intermediate dosing anticoagulation, and therapeutic dose anticoagulation. So there was a study that looked at these three options. And what came out from two studies really were what we call platform studies. So they looked at different interventions at the same time. And the outcomes were actually quite surprising. So they found that if you use therapeutic or intermittent dosing anticoagulation, there was an increased risk of harm. And the harm was an increased risk of bleeding. So you would think that if we put patients who have high D dimer, and it had nothing to do with the D dimer level. So you would think that the D dimer is an indication of inflammation, and in particular microthrombosis at the lung level. And starting the patient on anticoagulation may sort of improve the outcomes, but it actually did the opposite. It increased the risk of bleeding. So currently we recommend prophylactic anticoagulation as per the recommendations for all medical patients. So if the patient is on oxygen, immobile, at high risk of thrombosis, we recommend prophylactic dose of anticoagulation. And there was a small subset analysis done subsequently that's almost indicated that maybe patients on the ventilation may require a higher dose of anticoagulation, but I don't think we know that answer yet. So the risk benefit is in favor of therapeutic anticoagulation, and to only start, the risk benefit is in favor of prophylactic anticoagulation, and to only start therapeutic anticoagulation if you have a specific indication for therapeutic anticoagulation. Yeah, so this is a very interesting area that's not fully, the evidence is not fully available for us to give a fixed recommendation in terms of therapeutic or inhaled anticoagulation. Thanks.
Thank you so much for that brilliant response. I'm sure that all of us have learned something very, very interesting. I think we will all know that as the body of knowledge really in terms of evidence-based clinical practices improves, more robust studies are being conducted. There were quite a lot of interventions similar to this. Those of us that started really in a lot of ignorance last year also were giving, for example, hydroquinine to some of our patients as well. And really thank you so much, Doc, for answering that question very, very academically, and appreciate that. There are some more questions if you are willing to take some more at this stage. There's a question from Dr. Nkuna, who would like to know, in their hospital, the oxygen ladder says they can try high flow nasal cannula before CPAP. In the case that you are presenting, the client that you are referring to, Doc, was on CPAP and then high flow nasal cannula. Which is better and which is preferable? Over to you. Okay,
so the evidence and local experience, especially in the Johannesburg group of hospitals, shows that, if you fail one of the modalities, CPAP or high flow, the next step is ventilation. So you shouldn't move from CPAP to high flow, from high flow to CPAP. In this case, in our patient, it was really a practical decision. We use our CPAP machines in a high care environment, and we have the nursing doctor ratio to deal with it. Whereas when we move to the ward, we don't have that nursing doctor ratio, and high flow nasal oxygen is somewhat easier to manage in the ward, in the general ward, because the patient, once the setting is gone, you don't have to keep on coming to check about the fit of the mask, etc. So I think it's really a practical consideration of what's available in your setting. But moving from CPAP to high flow, I think, is actually a waste of resources, because you're wasting the circuits, and there's no evidence to show that doing that changes the outcome. In fact, in Johannesburg at the Joburg Gyn, if the patient fails one of the modalities, they go straight to for invasive ventilation. So that's just the local experience. I don't think there's any data showing that you should progress. So I'm not sure where that guidance came from. It's certainly not in the current South African guidelines. And can I just say, if you're looking for the clinical management guidelines of the National Department of Health or the NICD, it's on the knowledge hub of the Department of Health. Thanks.
Thanks for that. Are you ready for some more questions, or would you like to take them later, Doc? You can guide me.
Maybe let me just finish the discussion about this case, and then we'll stop again for more questions.
Thanks a lot. So colleagues, please just wait patiently. It will be worth the wait, I promise you. Thanks, Doc. Please, okay. Over to you.
Thank you. So when we look at sudden deterioration in a patient with COVID-19 and HIV infected, so the first thing we need to consider, is this a progression of disease in COVID-19? And I think a lot of people consider that in response to the MCQs. Is there another infection? Is there a non-benign lesion or something? You must remember, a lot of the patients come to us that are not part of our care or not in our care, so we may not know about background non-benign lesions, or they may present for the first time with a non-benign lesion. Is this a new vascular issue like thromboembolism or some other issue like pulmonary hypertension? Is it cardiac related? Or is this a new clinical issue as we move the patient out of the unit? So this was a nice summary presented in the Journal of Postgraduate Medicine, where it looked at, so what to consider in the setting of, in terms of infectious causes. So you can see a lot of the infectious causes are viral in nature, so adenovirus, influenza, human pneumovirus, parainfluenza, respiratory syncytial virus, malaria, tuberculosis, cytomegalovirus, pneumocystis caronae, pneumonia, and strongyloides infection. So I just want to highlight strongyloides infection. Because remember, in our setting, we're using steroids for COVID-19 pneumonia, And if the patient has strongyloides infection, the worms may then become active because you're immunosuppressing the patient. And so the patient's immunosuppression state will sort of activate the strongyloides infection. So that's something to consider in our setting. And then the other non-infectious causes are generally managed in a more higher level of care, but it's like the acute interstitial pneumonia, the cryptogenic organizing pneumonia, or an acute eosinophilic pneumonia, especially when you're weaning the patient off steroids. And then malignancy, like the bronchoalveolar cell carcinoma, lymphangitis, acute leukemia, and lymphoma. And then other non-infectious causes like diffuse alveolar hemorrhage, veno-occlusive disease, pulmonary embolism, sickle cell disease, but not common in our setting, of vasculitis and a dermatomyositis. And this generally can come to the fore when we're starting to wean off our steroids. So why did we think, or why is PCP important in the setting of an HIV-infected person with COVID-19? So 7% of patients who had influenza virus infection presented with PCP in the pre-COVID-19 era. So it's not something newly described with a viral infection. COVID-19 precipitates a lymphopenia. So, and dexamethasone therapy, which we use to treat severe COVID, also creates a lymphopenia. So this may further increase the risk of precipitating an event of pneumocystis carinii pneumonia. In our setting where we have an immunocompromised population, there's a predisposition to COVID, to PCP. And in a 2013 meta-analysis in the African setting, they found that the prevalence of PCP was 19% of patients presented with symptomatic PCP, whereas 9% can present with asymptomatic PCP. So it's important to have a high index of suspicion, especially in a patient with advanced HIV infection. But it presents also with a diagnostic conundrum because both COVID-19 and PCP can present with subacute hypoxic pneumonia. They have a non-productive cough, both present with bilateral ground glass infiltrations, both precipitate lymphopenia, or both can present in the setting of lymphopenia, and both have an elevation in the lactate dehydrogenase. So this was a study from looking at COVID-19 related respiratory failure and lymphopenia that do not seem associated with pneumocystis carinii pneumonia. So there were 423 patients who had assays for PCP and in 145 patients with SARS-CoV-2 infection in the setting of mechanical ventilation or ECMO. 22 of these patients had pre-existing risk factors for PCP, so they either had solid organ transport, corticosteroid therapy prior to hospitalization, or hematological malignancies. 6 had HIV infection, but 5 had a CD4 count greater than 200, and 1 had a CD4 count of 184. So this is in a setting where most people are already on ART. 113 participants had a lymphopenia of less than 1, and the positive PCR was only yielded 2 cases of PCP on bronchoalveolar lavage, and those that were HIV infected did not present with PCP, and the 2 that PCP was isolated on had low viral PCP loads. They were lymphopenic, and both patients had initial clinical improvement. However, they died within weeks from a superimposed bacterial infection. So this sort of is highlighting the challenge of making the diagnosis firstly, and then if the patient's already HIV infected, you may not actually get a diagnosis if you're considering PCP. When you look at the next study that was observational in nature, they looked at 108 HIV uninfected ventilated patients who had additional respiratory samples. 31% were on corticosteroids, and 80 had bronchoalveolar lavage. About 20% had tracheal inspirates. Less than 4% did sputa, and then bronchial aspirations in under 2%. And 9.3% of the samples were positive for PCP. So somewhat different results to the previous study. 9 of these patients had a positive beta D glucan measured, and 2 values were greater than 80. were already on Bactrim prophylaxis, and there was no significant difference in mortality between the PCP infected and uninfected patients. So you can see we're still not finding definitive evidence of an association between PCP and COVID-19, whether it's HIV infected or HIV uninfected. But what's PCP? So PCP is Pneumocystis carinii pneumonia. The organism's name was changed some time now to Pneumocystis hirschsprungi, and some people call it Pneumocystis hirschsprungi pneumonia. It's an opportunistic AIDS-defining fungal infection. We clinically suspect it when one's CD4 count is less than 200 or one has advanced HIV. As I said already, it presents with a subacute hypoxemic pneumonia, a raised LDH, and a beta D glucan. The chest X-ray can present with a normal chest X-ray early in the disease, but then as the disease progresses, you get this diffuse bilateral symmetrical ground glass interstitial infiltrates that start at the hila and spread outwards. And the atypical presentations can include nodules, blebs, cysts, asymmetrical disease, upper lobe infiltrates, interthoracic lymphadenopathy, and a spontaneous pneumothorax. So the diagnosis is made initially by maintaining a high clinical suspicion. The definitive diagnosis can be yielded by both a qualitative or quantitative PCR. This is a very specific test, but it cannot reliably distinguish between colonization versus active disease. And we believe that the higher the quantitative assay is, the higher the organism load, and it's more suggestive of active disease. The beta D glucan, so that's a newer test. It's beta D glucan is part of the component of the fungal cell walls. It's a sensitive test, but not specific. It's raised in many other fungal diseases. It can give you a false positive in the setting of other antibiotics, in particular peptazo, and also cellulose membranes may precipitate a positive test. But the sensitivity is greater than 94%, and the specificity is about 86%. So it has a high negative predictive value. So the CT findings of PCP, so we see these extensive ground glass opacities. When we looked at 32 HIV infected patients diagnosed with PCP, 41% had a central distribution of ground glass opacity with peripheral sparing. 29% has a mosaic pattern of distribution, and 24% had a diffuse involvement. So you can see even the CT scan is not very definitive. They have an upper lobe predilection, and if you saw enough COVID, you would realize COVID starts in the lower lobes and then moves upper lobe, but it depends when you see the patient. There's a greater degree of opacification noted in HIV uninfected patients, and you can see lung consolidation in uninfected patients. This is an indication of the crazy paving sort of features that I spoke about earlier on the CT scan. And it can be superimposed on the ground glass opacity with or without the intralobular lines. So when we look at the CT findings of SARS-CoV, again, it can present with ground glass opacities, but as I said, it's more peripheral than central as a result of the diffuse alveolar damage. Unlike other types of pneumonia, you see peribronchial thickening, which is the tree and bud presentation, is usually not observed in SARS-CoV-2. You get both intralobular and interlobular thickening, but we also see this PCP. And we see what we call the halo sign, which is the organizing pneumonia, but this could also be a fungal infection like muco or other bacterial infection. And the distribution is the most important differentiation. Upper lobe or central predominance suggests an alternative etiology. Lobar or segmental consolidation with air bronchograms are more suggestive of a bacterial pneumonia. And diffuse ground glass opacification could be suggestive of either severe COVID or PCP. So you can see it's not such an easy diagnosis to make, even if you have a CT scan. So the accuracy of radiological findings in differentiating SARS-CoV-2 was looked at in a study, and they saw variations in radiological experience and different disease patterns. So Chinese scientists predicted SARS-CoV-2 on CT scan. It ranged between 72 to 92% in terms of sensitivity. And there was a similar sensitivity in the American radiologists, but the specificity was 22 to 94% in the Chinese cohort and 93 to 100% in the American cohort. So you can see even the experts will have difficulty in differentiating in terms of specificity. So after we saw this case, I went to look at the literature. And fortunately, some time later, I saw this case that was reported out of Cape Town, Tygerberg Hospital, where they reported a 54-year-old man with a 3-week history of cough, myalgia, and progressive dyspnea. He had a medical history very similar to our patient with hypertension, but this patient had type 2 diabetes and had 2 previous episodes of sensitive TB. He was HIV infected, but this patient's CD4 count was low. It was 26. It was positive for COVID-19. He required nasal prong oxygen and progressed very rapidly to high flow nasal oxygen on day 2. The chest X-ray showed this bilateral, predominantly lower zone ground glass opacification. He had a lymphopenia of 0.69, a C-reactive protein of 157, PCT of 0.58, and a D-dimer of 1.02. His urine TB LAM and his gene expert was negative. So the blood, urine, and sputum cultures were negative. The tests for PCP and serum beta D-glucan and urinary Legionella antigen tests were undertaken. He was started on empiric high-dose trimethoprim sulfamethoxazole with dexamethasone. And they suspected a nosocomial pneumonia like we suspected in our patient on day 3 of admission and started him on meropenem and fluconazole. I'm not clear why they started him on fluconazole, but anyway. So PCP was confirmed with a D-glucan of greater than 500. Blood cultures yielded a positive Acinetobacter baumannii infection, and the patient died on day 8 of admission. So the comparisons with the patient I initially described, both patients were HIV infected. One had a CD4 count that was high and one had a CD4 count that was low. Our patient that had a high CD4 count was already on antiretroviral therapy for some time. Both were diagnoses with PCP, but it was considered at different stages of each patient's hospital admission and disease course. And I really brought out this case to show that it can present at any time during the admission. And if you don't consider it, you may miss the diagnosis. So Dr. Fizza, I think I can pause here if there's any additional questions before we move on to the next case.
Thank you, Doc. You actually answered one of the questions just a while back. There was a question specifically about the beta D-glucan assay. You have very adequately already given an overview about the significance of that in the diagnosis of pneumocystis jirovecii pneumonia. So that question was answered. In terms of a few more, there's a few short questions. The very first one is, what is wall-mounted CPAP?
Okay, so this is the new version of CPAP that we have, where we plug the machine into the plug point at the wall with the oxygen connection to the normal oxygen delivery system in the hospital. So that's as opposed to the CPAP that's connected to a ventilator, that you have to change the ventilator settings to use the CPAP. So the one is via ventilator, the one is that we plug directly into the wall and use the connection. So that wall-mounted CPAP is actually a South African innovation in the setting of COVID-19 that was done by the CSIR. So it only is the CPAP with nothing else, with no other gadgets attached to it. So it's all these CPAP machines that the National Ventilator Program rolled out in all the different settings.
You have actually just answered the follow-up question of the colleague who specifically wanted to know how it's different than opposed to the one connected to a regular ventilator, but you've definitely answered that very well. There are some more questions. Let me just quickly have a look in the chat function. There was a question specifically in your case presentation that there was mention that the patient had peripheral edema. There was mention that there was no evidence of acute cardiac failure. So could it possibly be that the patient developed peripheral edema as a result of prolonged corticosteroid therapy?
Definitely, that is a consideration. But I think in our patient, she had worsening renal failure, and I think they fluid overloaded her. Um, but peripheral edema is an adverse effect of corticosteroid therapy. So that's an important consideration. Thanks.
So definitely well spotted by a colleague in the audience. Thank you so much. Next question, Doc, is from Dr. Tabele Mnisi Msibi, who is concerned about the discharge of patients on home oxygen therapy, specifically with the fact that we know that we've got unstable and unreliable electricity supply within our country, erratic load shedding, and also outages in some of the suburbs. So it's not necessarily the fault of national rollout of load shedding. So do you have any specific advice? The doctor specifically mentioned here that there was an area where such a patient was unfortunately residing in, where there were outages for a good 2 weeks. So is there any suggestion or any advice that you can share with desperate clinicians out there what to do with people that are stuck in such a situation?
Yeah, no, I mean, we live in very difficult times, but I must say that we don't send patients home without doing an adequate assessment of whether they can cope with home oxygen. So I agree with you, there's no point sending a patient home in an environment where there's no backup systems if the electricity fails, or they don't have access to come to hospital immediately should they not be able to get oxygen at home. So that's definitely a challenge, and I think it's an important aspect. I must say we've had a few oxygen failures within the hospital also for basically oxygen supply pressure issues. But this COVID-19 times is a very different era that we practice in. But certainly you shouldn't send a patient home for home oxygen if you haven't done a proper assessment of whether they will be able to cope in the event of having electrical issues or supply issues or other environmental issues. Thanks.
So that concludes the questions for now. You are welcome, Doc, if you would like to continue with your presentation, and then colleagues that's in the audience can post your questions, and it will definitely be attended to. Thanks.
Yeah, thank you very much for your interesting and challenging questions. So the next patient is a 53-year-old man who presented to us with a 8-day history of fever, anorexia, malaise, shortness of breath, and a dry cough. Once again, positive PCR for COVID-19, and initially admitted requiring only nasal prong oxygen. Of particular importance in his history, he was a healthcare worker, but reported no illness of note or tuberculosis infection in the past. BMI, again, slightly a high BMI. Chest, again, using accessory muscles of breathing, but he had decreased air entry bilaterally in the right upper lobes. And he was of unknown HIV status, so we tested him for HIV, it came back positive. And we also did a urine TB LAM at that time. I know you have to wait for the CD4 count, but when our patients get admitted to the COVID ward and are HIV infected, we generally screen them for TB immediately with the urine TB LAMs to sort of speed up things. So the urine TB LAM came back positive. These were his bloods again, as you can note, creatinine abnormal, again, lymphocyte count low, viral load greater than 300,000, clot negative, D-dimer not so high, but C-reactive protein and LDH elevated. So we made an assessment of COVID pneumonia. Again, we were unsure whether it was in the hyperinflammatory phase. He had renal impairment, newly diagnosed HIV, and with a likely diagnosis of disseminated tuberculosis. We didn't have an X-ray on him, but we placed him on nasal prongs, and he very rapidly progressed to requiring a rebreather mask. It was escalated to high flow nasal oxygen. He was started on prophylactic enoxaparin, dexamethasone 6 milligrams daily, and commenced on Rifampicin. Now, we debated quite a bit about whether we should give him dexamethasone in light of the tuberculosis, but in the end, he was COVID-19 positive, requiring oxygen, and we didn't know whether and rapidly increasing oxygen needs. So we just opted to give him the dexamethasone. And then he maintained his peripheral saturation very nicely on the high flow nasal oxygen. So our current assessment was that of a patient with AIDS with COVID-19 pneumonia and disseminated TB. So when we look at the South African data, so initially when this patient came in, it was about June 2020, and we didn't have enough information on COVID-19, TB, and HIV. But in around about 12 September on Twitter, I found this report that was released by the NICD, which looked at the case fatality rate in patients who had HIV infection, previous TB, or current and previous TB in the setting of COVID-19. And you can see that whilst we were all focusing on hypertension, diabetes, and other comorbidities as a risk factor for mortality in COVID-19, it was rapidly emerging that HIV, previous or current TB, or current and previous TB had just as high a mortality rate. And if you recall, our patient also had a raised BMI, so he had multiple risk factors for poor outcomes with COVID-19, HIV, TB, and a high BMI. And then subsequently this year, and I was part of the study by way of disclosure, this was the study done by the DAT-COV data, which the NICD collected from every hospital, both in the private and public sector, and they published it in Lancet Infectious Diseases, I think it was last month. And what you can see here is that whilst age is a significant risk factor, tuberculosis, whether they had TB in the past, if you didn't have TB previously, or you had TB in the past or current TB, your risk of mortality was significantly increased, even if you combine it to other things like diabetes, etc. While it was slightly lower, there was a significant risk of mortality in our hospitals in South Africa in patients who had COVID-19 and tuberculosis, either in the past or current diagnosis of tuberculosis. So this does seem to be an emerging theme, that people with TB and COVID-19 have poorer outcomes. So I put this in mainly to see, this was our previous risk of progression to TB disease compared to the general population, that if you had AIDS, you had a risk of TB, HIV infection. If you had previous silicosis, fibrotic lesions, cancer, immunosuppressive treatment, the relative risk of TB was increased. And now we need to include COVID-19 and other viral infections as a possible risk of having a poor outcome with tuberculosis. So HIV accelerates TB progression following exposure. There's an increased risk of TB outbreaks, including MDR TB in the setting of HIV and TB. And there's an increase in smear-negative TB in the setting of HIV, but there seems to be a lower risk if they are smear-negative in terms of transmission of TB. TB is associated with decreased HIV survival, and TB infection accelerates a patient to AIDS or mortality following TB treatment. And there's an increased risk of recurrent TB, usually exogenous infection, if they're HIV infected. And the presentation of HIV infection affects the TB presentation. And this is really influenced by the degree of immunosuppression. Some presentations have remained unchanged, like the TB meningitis and the TB osteitis, but we tend to see subclinical or subacute TB infection. And we know this because we did an autopsy study at Edendale Hospital here in Pietermaritzburg, and we found that a lot of patients had unsuspected TB. And I think that's what's happening in the setting of COVID also. People are presenting with tuberculosis and COVID-19, and we're not suspecting it in the COVID wards. And then TB can present with peculiar syndromes like lymphadenopathy only, with no other evidence in other sites, with pulmonary syndromes. So you can have sort of a pleural effusion with chest infiltrates. You have lots of serositis or ascites, pericardial effusion, pleural effusion, and then just constitutional symptoms. And that's where we need to, we need to bear in mind that TB can be smear negative despite being culture positive. And this is a reflection of the poor immune response to TB in the lung in an HIV immunosuppressed patient, can present with an atypical chest radiograph and extrapulmonary presentation of TB, and patients can rapidly deteriorate if TB is untreated. So I put this slide in mainly just to remind everybody on the TB diagnostic tests available together with the sensitivity and the specificity. So our initial gene expert tests in the country tested for rifampicin sensitivity. Our turnaround time was meant to be 48 hours, but I think in many settings it's more than 48 hours. But the sensitivity and specificity of the gene expert is quite high. The Gene Expert Ultra, which is a modification of the Gene Expert, originally increased the sensitivity to 100%, but decreased the specificity to about 96%. And then the line probe assays assist us in differentiating between tuberculosis, Mycobacterium tuberculosis, and the non-tuberculosis mycobacteria. In addition to that, it gives us the sensitivity to ironage, but we lose sensitivity and some specificity in using those tests. Culture, well, the specificity is 100%, the sensitivity is 82%. Although it takes very long, we can get sensitivity to other drugs also. And then our old method, which is sputum smear microscopy, it doesn't detect resistance, had a low sensitivity, but had a very high specificity. And then the new kid on the block is the urine TB LAM. And we currently recommend it for those with a CD4 count of less than 100, but there's talk about increasing that threshold to 200. Whilst it's not a very sensitive test in some settings, in the setting of HIV infection, it has a good sensitivity and specificity. But when you start using it in HIV negative patients, you start to lose the sensitivity. So the other thing that we're very familiar with is that ART reduces the incidence of HIV-associated tuberculosis by more than 80% in some studies. And you would note that this patient had advanced AIDS and was not on ART. So if you have TB and HIV, we commence ART irrespective of the CD4 count, but we start TB treatment first, then we start ART, and we try to assess the readiness of the patient to start ART as soon as is indicated. Our regimens currently available is we have the new regimen of tenofovir, lamivudine, dolutegravir, but we also still have the option of using a efavirenz-based regimen. And then the modification of the regimen would need to occur in the setting of renal impairment or anemia. Currently, we're not using nevirapine in the setting of tuberculosis because of overlapping hepatotoxicity. One needs to remember that if you have a patient with, who's diagnosed with TB, requires ART, and requires cotrimoxazole, we need to start TB treatment as a priority, then initiate antiretroviral therapy, and then consider starting cotrimoxazole. Try to avoid starting all these agents on the same day and space them out because you can have additive side effects. And cotrimoxazole is important to start because it reduces the incidence of malaria, bacterial pneumonia, and enteritis, and not only prevents pneumocystis carinii and toxoplasmosis. So I have my third question, so I'm going to pause here for the poll. And my question is, when would you initiate ART in the patient I just discussed? Thanks. So the first option is so I'm just waiting for the poll to come up. So the options would be stop TB treatment and immediately start ART. Double the dose of dolutegravir when you're starting ART. Dolutegravir may not be given to patients on TB treatment. Refer this patient to a specialist or start the patient on a lopinavir ritonavir-based regimen. The majority is in favor of doubling the dose of dolutegravir. So that's the correct option, or the preferred option, I should say, that we want to use. But remember, we're doing a BD dose of dolutegravir, 50 milligrams twice a day. And then remember, when you're stopping TB treatment, you need to continue the higher dose of dolutegravir for at least 2 weeks after you stop TB treatment, so that the enzyme induction stops before you reduce the dose of dolutegravir. So starting lopinavir ritonavir is an option, but it's a poorly tolerated option because you need to increase the dose of lopinavir ritonavir, and that has increased side effects. And I mean, another option would be an efavirenz-based regimen, but that also has neuropsychiatric side effects. So one would need to, so that was a trick question, stop treatment immediately would be actually to continue TB treatment once the patient's tolerating TB treatment, to consider starting antiretroviral therapy. So Dr. Fissa, I'm happy to pause here if there's any questions, and then, or do you want me to proceed?
Thanks, Doc. There's actually one question and one comment. Or actually there's more coming through now. So the comment basically just says that in the updated urine LAM guidelines, the test can be done in patients with a CD4 less than 200. So that is official already. The question is first question is in terms of the study that you presented, that you said that you participated in the study, you mentioned that race is a risk factor, and the colleague wanted to know what could be the attributing reason. Could it be because of a genetic predisposition, or could it be because of access to, or limited access to, usually quite poor healthcare services in terms of race as a risk factor?
Yeah, so I think in these sort of studies, it's a reflection of access to healthcare. Because the only way you could say that is if you do genetic studies. And this was, so the limitations of the study is that these are patients who got to hospital, okay? So you need to have the means to get to hospital. And if you recall, during our second peak, a lot of places ran out of beds, and ambulances, there were very few ambulances available to transfer patients. I know lots of times patients waited more than a day to get transferred to hospital. And obviously, there was a delay in acquiring healthcare. So I think it's a reflection of access to healthcare rather than a genetic basis. But there's a lot of studies going on looking at genetic risk and COVID-19. And I think in time we'll get more sort of indications of genetic profiles that are more at risk for certain viral infections. But even when you look at genetic risk, it depends on the type of study you do. So in the US, there's lots of these studies that collect, people use the postal system, send their sort of cheek swab in, and then these people store it. And then I know they would be looking at is there what genetic profile would be high risk of acquiring COVID-19, and they came out with a few HLA prototypes. But there's a bias in that sort of study because you're basically on a fishing expedition. People who, there's a different profile of people that will volunteer and give you the genetic material. And then certain people will not allow certain studies to be done on it. So already there's a bias in terms of selection of who does those sort of tests. So if we meant to determine if there's a genetic risk, we would need to do a properly conducted study prospectively looking at genetic profiling. Thanks.
Thanks for that, Doc. So a follow-up question is for how long will you delay the starting of Bactrim to prevent additional side effects?
So generally, it's 7 to 10 days. So I generally look to see that they're tolerating the first drug regimen that I introduced. So roughly about within a week, they should be tolerating it, and then I would introduce the next drug. Just be careful when a patient's on prednisone, and I had this experience previously. I had a patient on prednisone for PCP, and the patient was on Bactrim, and as we weaned the prednisone, she developed Stevens-Johnson syndrome because the prednisone was suppressing the Stevens-Johnson syndrome, and so she was allergic to Bactrim, but we only saw it when we weaned off the steroid. So it's important to observe patients when you're doing changes in drug regimens or introducing new drugs. Thanks.
And then the next question, Doc, and you can really tell me when you would like to proceed with your talk. The next question asks specifically, did you say stop the double dose of dolutegravir 2 weeks before stopping the TB treatment?
What I said is, sorry, I may have misspoke. Continue with the 50 milligrams BD of dolutegravir for 2 weeks after you stop the TB treatment. So to give that enzyme induction to reduce so that you don't lower your levels of dolutegravir.
Thanks. I'm just quickly looking at the chat function for additional comments. Dr. Kindoki was asking about the conducting urine LAM not done when CD4 is less than 200. Comment from Robert says, good point on risk factors for progression of TB infection to disease, also with noting high risk posed by diabetes mellitus for both TB and COVID-19. And then a comment, Dr. Noswat Alam says, we do urine LAM test in all suspected TB patients, HIV positive, regardless of what the CD4 count is. Any comments from your side in terms of utilization of urine LAM or anything that you would like to add, Doc?
Yeah, so be careful of doing it. I mean, I think it's a cost-effective thing as you go above a higher CD4. So initially the data was quite robust for CD4 count of less than 100. Now we've got additional data for CD4 count less than 200. But I think as you go to a higher level CD4 count, your sensitivity and the specificity sort of decreases. So, you know, it's got a high specificity in the CD4 count less than 100. So all that's telling you it's a rule-in test. So, you know, it's easier to get a urine sample than to try and get sputum. So as you go to the higher CD4 count, so if you're doing it, it's okay. I don't know if it's cost effective because I haven't really looked at it. But also bear in mind that you're losing your sensitivity and specificity. So if you don't get an answer, you need to find another way to make the diagnosis. So don't use it as the absolute screening intervention. Thanks.
Appreciate that response.
And then the comment about, that's a very good comment about the risk of tuberculosis in the diabetic patient. I think that's a very important point. And also the risk of other fungal infections in the diabetic patient with COVID-19 whom you're putting on corticosteroids. Thanks.
That concludes the comments and questions for now. You're welcome to proceed.
Thanks. So I think we don't have that many slides left. So that would get us within our time. And if we have any additional questions, we can have a bit of a discussion. So just to remember that in the setting of COVID-19, tuberculosis and HIV, want to start treatments, be aware of drug interactions. Okay, so rifampicin and steroids. Steroids may affect the concentration of rifampicin, shared or cumulative toxicities, high pill burdens. And then if you're starting ART, immune reconstitution syndrome worsens TB. And then we don't really know when's the optimal time to start ART in the setting of COVID-19. And the current recommendations, both locally and internationally, is to wait at least 2 weeks. But that's based on the evidence we have for other opportunistic infections. And I think this evidence will evolve with time about when's the optimum time to start ART in a patient that's post-COVID-19 and HIV infected. So in summary, HIV makes TB worse and TB accelerates the progression of HIV. COVID increases mortality in the setting of HIV and TB. The diagnosis of TB can be a challenge in the presence of HIV and now worse so in the setting of COVID-19. Beware of immune reconstitution syndromes and drug-related effects, especially if the CD4 count is low. and monitor for overlapping toxicities and drug interactions. And when you're discharging the patient, educate the patient about pill burdens and possible side effects. So the global COVID-19 pandemic is been with us for more than a year. It's important to exclude other causes of pneumonia, especially tuberculosis and pneumocystis carinii. TB and advanced HIV is a diagnostic challenge and may be more difficult in the setting of COVID-19. And it's important to screen all HIV and TB at all hospital admissions so that we don't miss the diagnosis of HIV and TB, especially in the setting of COVID-19. And I just want to end by talking about our plan for tuberculosis was that we wanted to decrease the incidence of TB, and we had specific targets that if we optimize the use of all the tools we have for tuberculosis, we could decrease the TB incidence by 10% per year by 2025. And unfortunately, our plan was to introduce new tools, possibly a vaccine, prophylaxis, point of care testing. We could decrease it by a further 17%, but then COVID came and upended all our plans. So I think it has set back the projection for decrease in TB incidence quite significantly. Hopefully, once we get everybody vaccinated, we can start concentrating on TB incidence and TB elimination. So I'm going to stop there. I'm happy to take any additional questions. Thank you.
There's a lot of compliments flooding in for you for your great presentation, but before I start reading them, there are some more questions, if you are ready for that, Doc. The very first one is in terms of risk of RIF-resistant TB. In HIV positive clients, is there any evidence for direct link?
So I think we haven't really seen an increase in MDR-TB. In fact, when I speak to my colleagues that work in MDR-TB, they actually saw a reduction. And what's happened, sadly, in COVID-19 is a lot of the units that were used for MDR-TB were taken over by COVID-19 infection. So I think this is anecdotal. So I'm starting to see an increased number of drug-resistant TB, but I can't quantitate it for you. So I think once things start to settle with COVID-19, we may see some MDR-TB, but remember also that lots of people are wearing masks. So whether that has reduced the transmission of tuberculosis in general and maybe MDR-TB. The other thing is lots of people were untreated, so maybe poor adherence hasn't sort of induced more MDR-TB, but certainly, you know, I normally see about 1 to 2 cases per year of MDR-TB in my tertiary setting. Currently, I've seen 2 cases in the last month. So I think we'll need to monitor it because our TB diagnostic rate has gone down. It's increased somewhat in the last year. But I think that's a very important thing to watch to see what's going on. Hopefully wearing a mask and social distancing and increasing ventilation has reduced TB transmission. Thanks.
A next question from Dr. Nkuna asks specifically whether there is any evidence whether COVID-19 causes hyperglycemia. I know anecdotally a lot of clinician colleagues have informed me that there's patients that develop frank diabetes after the patient recovered from COVID. So any specific mechanism that results in hyperglycemia in patients who have COVID-19 infection?
So, yeah, so that's a great question. I don't think I can answer the question because I think the evidence is evolving, but there's 3 different types of presentations of hypoglycemia we see in COVID-19. So first, you'll see the patient who is a known diabetic who gets a COVID-19 infection and then has difficulty in controlling the glucose levels because of the co-infection. The second setting is the undiagnosed diabetic who comes to hospital, who may be what we call the pre-diabetes. We put the patient on corticosteroids, and then we make a diagnosis of diabetes. So it precipitates higher sugars, so we make the diagnosis of diabetes. And the third category is the category of patient who has where COVID-19 affects the pancreas and then precipitates diabetes. So that third category, the evidence is still evolving. There is a few basic science studies suggesting it, but I think it's three different scenarios, and that last scenario is the scenario that sort of needs more exploration. Thanks.
So Dr. Alam asked a question, and I think all of us will agree that we didn't really see many people with flu last year because obviously of the fact that we have increased our hand hygiene, social distancing, and mask wearing that's mandatory as public health interventions. So Dr. Alam's question is specifically, is there any impact on TB incidence now that there's compulsory mask wearing? Are we going to start seeing less infection rates, drop in the incidence? What are your thoughts, Doc?
So, I mean, I think I'm hopeful that we'll see an increase, but it's too early to tell. And part of the reason is because when you look at the NHLS data, our testing rates for tuberculosis has reduced. So we can't really tell if the decrease in TB that we're seeing is because of lack of testing or lack of presentation for tuberculosis, or is it really because of the non-pharmaceutical interventions? So I think we'll be able to tell in time once everybody gets vaccinated, etc. And if the screening for tuberculosis rates come back up to pre-COVID-19 levels and our incidence goes down, then only we'll be able to tell.